This
I have some.
conference will now be recorded.
Okay.
All
Um,
right.
and here we go. So,
Okay.
um, we will be, this is just like a smattering of updates in ovarian cancer. Like, obviously, this is not exhaustive. And obviously, I had to make this sort of like not, I did not want to make this complicated. I like the slides, obviously, that are presented at like our research meetings are complicated, they're jumbled, and they're somewhat hard to understand. And like it would take me like 4 minutes to explain each slide, and I don't think we need to do that. So this is some like distilled information, and honestly, this is how I would be talking to you if you were sitting in my office talking to me about these things. So I figured that's pretty much what this is. This could be just how you were talking to me if you were in my office. So that's how I like to do these things. Okay, so I guess Susan, I'll tell you slide.
Yep.
So basically, they told me that, and I'm going to drink a Diet Coke because I drink about 4 of these a day. It's been a long day. So one of the things that Susan really wanted to touch on was understanding PARP inhibitors in ovarian cancer. Realizing that there's, yes, PARP inhibitors are one of the most exciting things that are out there, but obviously there are so many other questions that you guys have, right? Like, tell me about immunotherapy, tell me about antibody drug conjugates. I always get asked about Hypec. Hypec is not something we do at Metro Health, so I'm going to touch on it for like a minute. I'm happy to answer questions about it, but there are a lot of new and exciting things, and PARP inhibitors, quite honestly, are almost getting to the point where I'm going to say they're old hat, because right now they're just sort of FDA approved, they're in the NCCN guidelines, and everybody is going to be on a PARP inhibitor at some point in the course of their ovarian cancer. So we're basically going to touch on how do PARP inhibitors work, why do they work better for some ovarian cancers over others, how are these drugs used, what is the difference between maintenance and treatment, and what does that mean. And it does get very complicated when you think about how the FDA actually approved these drugs. It gets complicated for patients, and I assure you it still gets complicated for doctors, okay? Because there's 3 drugs and they still have 3 different FDA approvals, okay? What are the common side effects of these drugs? And how do I know if these drugs are an option for me, you asking this question as the patient? So how do PARP inhibitors work? So when we think about DNA replication, right? So DNA replication is basically the sort of at the heart of everything we're talking about. Cancer cells are rapidly dividing cells. They must replicate their DNA. We know that DNA replication is an extremely error-prone process. Um, and when these errors occur, the cell actually can't survive and apoptosis occurs, apoptosis being cellular death. Now, we can't have that happen all over our body. I mean, we would never have survived as a human species if we didn't actually have ways to repair the errors that occur. So you can see in this little cartoon here that we have an error, an area of sort of DNA damage right there. And the PARP, which is an enzyme, comes on in, identifies the area of DNA damage, repairs the area, and you can actually see, yes, honey, bye, I'll pick you up. You can actually see where they're bringing in the DNA to repair the area. And what happens? We get cell survival. Ta-da, the cells survive. Um, if we actually can't repair that area and we deactivate the PARP, then we actually get DNA collapse, and the DNA, the cell will actually die by a variety of mechanisms. Apoptosis is actually just one of them. So in we'll let them bark as the teenager leaves the house. Um, so in a healthy cell, obviously this is not something we want, but in a cancer cell, this is a really good thing. We would love our cancer cells to not be able to repair their damage and to undergo apoptosis. And so you can see actually by this very simplified cartoon why inactivating a PARP with a PARP inhibitor would actually be a good thing. This is a very simple way of looking at it, but this is the easiest way to understand it. So why do they work better in some tumors? So we all have heard, right? yes, PARP inhibitors work really well in patients with BRCA1 and BRCA2 mutations. Yes, they do. And these are actually the very best patients to use these drugs in. Why? Lulu! Because patients with BRCA1 and BRCA2 mutations actually already have a problem in repairing DNA damage. So they already basically have, we'll call it one hit. So they already have a problem, one hit in repairing DNA damage. So as soon as we bring in that PARP inhibitor and think back to that cartoon, it's like the double whammy for the cell. This cell now basically has no hope, like no hope at survival. So basically, as you can see here in the third line down, PARP inhibitors enhance that difficulty. So basically, it's this amazing enhanced effect that we get. So how do we wind up with these mutations? Well, for some of you sitting out here, you may have an inherited defect in BRCA. You may have a BRCA mutation, or we can actually just get problems in BRCA in the tumor. And that's called a somatic mutation. That means that is not a problem that we've inherited. It's not a problem that we can pass on. It only happens in the tumor, but the effect is still the same. So even though we haven't inherited it, we still get the same effect, and we still get that enhanced effect of the PARP inhibitors. I'm not going to delve into details, but there still are some other sort of problems in DNA repair that we can see. One of them is called HRD. That also gives us a very similar outcome to having a BRCA mutation, and patients with these HRD problems also get the enhanced effect of the PARP inhibitors. And these are also tested for when we are sending your tumor for special tests like foundation medicine and things like that. And so we are looking for all this when we're testing your tumor. So you know what these drugs are. You know them. You love them. Lynn Parsa, otherwise known as olaparib, Zejula, otherwise known as niraparib, and Rubraca, otherwise known as rucaparib. And these are the 3 FDA PARP inhibitors that we as GYN oncologists have at our fingertips and that we use in our patients. You will have to forgive me. These slides were a little bit old, so I did my best to update them when we get down to where they are FDA approved, but there may be something that's a little bit behind the times in here, but I did my best to update them. So what is the difference between maintenance therapy and treatment? So we all know what treatment is, right? Treatment is we are treating the cancer. We are either in our adjuvant phase of treatment, meaning we have just had our surgery, and we are now having our first line of treatment, or our cancer has come back and we are being treated. Maintenance therapy is we have just finished, typically, a platinum-based regimen, whether it is first line or recurrence. We are typically no evidence of disease, or we've had a partial response, and we are now going on maintenance treatment to try to prolong our progression-free survival. So that's the difference. So treatment is we're using our PARP inhibitor to actually shrink tumor, and maintenance is we are using the drug when we are, and just for ease of words, I'm going to say when we are without evidence of cancer, when we're in remission, and we're using the drug as maintenance to prolong our remission. All right, I think I just actually explained what exactly was on that slide. So what are the benefits? I mean, for decades, we had no maintenance therapy to give. I mean, this is a game changer. You finished your treatment, we shook your hand, and we said, come back and see us in 3 months. We'll check your CA 125. And it was like, okay, best of luck to you. And yes, and that works in many ways, and it works in many circumstances, but it certainly doesn't feel good, and it doesn't feel good to the doctor, and it doesn't feel good to the patient. It doesn't feel good to anybody involved. So for many, many years, we were trying to find a maintenance drug to give. We tried everything. We gave patients, if you can believe it, we gave them like versions of Taxol as maintenance treatment. I mean, can you imagine getting more Taxol when you have no evidence of cancer? Patients did not like that very much, and some of them wound up in wheelchairs from their neuropathy. But this was a game changer for us because we felt like at least we could actively be doing something to help improve remission. So obviously, what are the benefits? Well, if you are no evidence of disease, we hope it keeps the cancer from coming back. And as of right now, I have patients that have been 2 years on Parp inhibitors with no evidence of cancer. It's amazing. Or it can take care of some small volume disease, which is why these drugs are indicated in patients that have not just had a complete response, but that have had a partial response, because we know there is anti-tumor activity. So this might be great for a patient that has just had, let's say you've just had your first recurrence, you've had a platinum sensitive recurrence. Let's say you've just gotten carbo and Doxil, you've had 9 cycles, you're pretty pooped from being on chemotherapy, you've had an excellent response, but there's still like a tiny volume of disease, but it still is almost an 87% improvement over what you started with. This might be a great drug for you because you get to get away from the chemo, which has made you feel really awful. Maybe you've had some bad side effects from the Doxil. And we know that there's going to be anti-tumor activity from the Parp inhibitor. What are some disadvantages? Side effects. So we're going to talk about the side effects. Treatment cost. I would say that treatment cost, in the grand scheme of making your brain think about the societal cost of cancer care, maybe. But even for patients that have no resources, these drugs are covered. So I would say in the grand scheme of things, like I serve a patient population that is underserved and without a lot of resources, and these drugs are covered for all of my patients. So I don't tend to think of treatment costs a lot when I'm thinking about these drugs, because I think everybody deserves world-class care. But I guess in this way of thinking about how much we spend on drugs in society, I guess we would think about this. More doctor's visits. I suppose I think my patients actually like coming to the doctor. I think most of my patients feel nervous when I tell them, oh my gosh, sorry, a patient just said hi to me. Hi. I think my patients get anxious actually when I tell them that they can come back in 3 months, and they're like, are you sure? Are you sure you don't want to see me sooner? So I actually think that they don't mind coming back more frequently. And limited information on long-term side effects. But honestly, I think we have enough data at this point. We've been using them for enough years that we can say that these drugs are safe. We know that long-term, all the chemotherapies we use can cause cancer. If we use any of the chemotherapy drugs long enough, we can cause myelodysplastic syndrome and leukemia. And yes, I have seen that twice now in my career in patients that have been on chemo just for so long that they developed secondary leukemias. We know that rarely we can develop leukemia when using Parp inhibitors, and I'm going to assume that if we use these drugs long enough, we will see it. We just haven't been using them for that long yet. And most patients, I don't think, are going to be on and off Parp inhibitors for 10 years. I just don't think that's how we're going to use them. Okay. We'll briefly go over all 3 of them. I apologize. We run like a rescue in my house. We have 3 rescue dogs here, so there's always some barking going on. Okay, next slide. We'll hit the first one. Okay, so Lynn Parsa. So this was actually the first FDA approved drug that we worked with. Lynn Parsa is the one otherwise known as olaparib. So right now, olaparib is approved for maintenance therapy recurrent. So recurrent maintenance therapy, not after first chemotherapy. So after first chemotherapy, you will be given either Zejula or Rubraca. It is indicated for in maintenance therapy with Bevacizumab in patients with HRD tumors. As maintenance therapy, again, for complete or partial response to their second platinum chemotherapy. So again, this is just as a patient who has now had their first recurrence, and this is after platinum-based therapy, and any mutation. So it doesn't matter. You can be Brca wild type, Brca mutated, it doesn't matter. We use Lynn Parsa also in treatment for women who have inherited Brca mutations who have been treated with 3 or more lines of therapy. And you will notice that the PARP inhibitors don't show up in treatment until a little bit further down the road. So it's not something that we're using in first line treatment or even really second line treatment unless you're on a clinical trial, because we just have other cytotoxic agents that we're using before PARP inhibitors. Okay. Lynn Parsa, the most common side effects are going to be nausea. So you definitely will be given Zofran, an automatic Zofran prescription with this drug. Fatigue is a big side effect. A low red blood cell count, a low neutrophil count. With all of these drugs, we are regularly checking your CBC at the beginning when you start on them. Again, with the nausea, you can have vomiting and you can have some diarrhea. This is typically a well-tolerated drug. The fatigue is one of the biggest things to get past. And usually once patients get over the hump, they tend to do okay. Rubraca. Rubraca is FDA approved for treatment, Brca mutation inherited or somatic in the tumor, and treatment for 2 or more prior therapies. So they were really proud of themselves because Lynn Parsa is indicated for 3 or more prior therapies, and Rubraca was happy that they were indicated for 2 or more prior therapies. And Rubraca is maintenance therapy, complete or partial response to platinum-based treatment. This is all comers. So Rubraca is one that you may be given as maintenance treatment after platinum-based treatment. I tend to like to use Rubraca because we don't tend to see problems with the platelets like we do with Zejula, and we'll talk about Zejula in a minute. The most common side effect with Rubraca, not so much nausea, it's more like abdominal pain and GERD. So with all patients, I give Nexium or Pepcid, and you take it every morning. So as soon as you wake up, you take your Pepcid or your Nexium, and even if you're like, but I don't have heartburn or reflux, I'm like, you still take this every single morning. Fatigue is a big complaint with this again, and this is one of those where we hope you can sort of get over the hump, and once you get over the hump, usually it's well tolerated. Changes in taste, and I should say with all of these, we can see laboratory abnormalities. They are typically not laboratory abnormalities that we then pass on to you, because we worry about them, and actually we don't even worry about them because they're typically not clinically significant. We can see elevations in your liver function studies, in your creatinine, but they typically are very transient. They have no clinical significance, and then they go back down. So it's something we know is going to happen, we're prepared for it, and then we know they're going to normalize. And Zejula. Zejula was sort of like the last comer here with all of its FDA approvals. It's the one with the most recent FDA approval. So maintenance, first line platinum-based treatment, all women regardless of mutations. So this is like sort of where you will hear GYN oncologists like arguing about this, and arguing about whether, like, what is the benefit to women who do not have these mutations. Because when you really look at the data demonstrates essentially a 4 to 5 month improvement in progression-free survival with a PARP inhibitor. We saw the same improvement in progression-free survival with bevacizumab. So this is like where we sort of start to get into the weeds of, are these drugs worth it? Because it is still side effects. It is still cost, because I don't want to be flippant about the side effects. I also have had patients stop these drugs because of the side effects. So yes, full disclosure, I've had patients go off of them because they cannot tolerate them. So we have to ask ourselves, for patients that do not have BRCA mutations or HRD, is it worth it to be on this drug? My answer is going to be yes, because I feel like the era of us sitting idly by and just saying, peace out, see you in 3 months, we'll check your CA 125. I think that era is over. I do. I'm glad it's over. But I understand being skeptical because the data is sort of wishy-washy. And if you don't want to feel like crap being on a drug that maybe gets 4 months in progression-free survival, then maybe you will really talk to your doctor about it and be like, yeah, I'm not interested. And I do have patients say that to me too. So in full disclosure, I have patients that also say, I am not interested in taking this drug. And I 1,000% respect that. And again, Zejula is indicated for treatment just like the other ones too. Zejula, really not the same side effects, some nausea, but really the biggest problem with Zejula is the neutrophil count. And in some patients, we just cannot use this drug because of their neutrophils. We cannot keep their neutrophils up. I mean, it's so bad that the drug company had to come out and be like, we have a fun new way to dose the drug. It's called weights and plates. So essentially, in very thin women who at baseline have low platelets, we have to dose reduce you to like 200 milligrams, I think, was your Zejula dose. But most of us honestly just dose reduce anyway, because we know that the platelets are not going to tolerate it. But because the first doses of Zejula were so toxic to the platelets that nobody could tolerate Zejula, and we all essentially didn't give this drug when it first came out. So I think the drug company was like, we have to figure out a way to get doctors to actually prescribe this drug because they don't like it. So there is a dose reduction, but we basically use the dose reduction in everyone to allow for their bone marrow to tolerate it. But they all can have this low-grade nausea and fatigue and everything. So PARP inhibitor side effects, most of the GI side effects are seen with Rubraca and Lynn Parsa. All of them have this like 1% risk of myelodysplastic syndrome. That is why we are checking your CBC frequently at the beginning. If for some reason we have 4 weeks of neutropenia, we will actually refer you to a hematologist. It is not that we are being anal. It's not that we're being alarmist. It's that we need you to have a bone marrow biopsy, and that's what we're actually referring you to the hematologist for. It's for them to do a bone marrow biopsy so that we can make certain that we are not developing a secondary leukemia from the PARP inhibitor.
Are you ready for the next one?
Sure.
All right.
Okay, so olaparib, used for maintenance in certain circumstances, treatment, yes. Treatment schedule, twice daily. Ignore that 8 capsules twice a day because that's like super old. Like, yes, that's how we used to have to do it. Can you imagine taking that many capsules? It was bananas how it used to be dosed. Yeah, thank you.
Scratch it out.
Yeah, crazy. Patients were like, I can't take this many pills. And I was like, I know, I'm so sorry. Brca, so yes, it is a maintenance treatment now. It's treatment, also a twice daily schedule. Zejula, maintenance, yes. Treatment, yes. Once daily. So all pills, all available. When you finish your upfront first time adjuvant chemotherapy, the drugs that you will sort of, the first drugs that will be looked at for you will be either Rubraca or Zejula.
Oh, hang on, I'm still on the paint mode. Oh, I thought I was so fancy doing that
I
thing,
know
and now
you
I
could
can't.
be having fun
I,
and like drawing
I was
on
like,
all
oh,
my
look at
slides.
that. But now I can't advance the slide. Make that go away. Yeah.
Oh, you're still on a little paintbrush. We're
This
like
has not been
the blind
our
leading the
day,
blind
right?
here, Susan.
Oh my gosh. Okay, go away, paintbrush.
I can't even see. I don't even know what you're doing to see how you can get rid of the paintbrush.
Anyone know how to get rid of the paintbrush? Let's see. Fade out,
we need-
start drawing. Oh my gosh. Okay.
I'm gonna Google it.
I'm sorry, guys. My people in my support group are laughing at me.
Getting rid of paintbrush in GoTo. It's now called GoTo.
Yeah.
Oh my God. Pour any white vinegar into a pot and bring it to a simmer or a boil. That's like how to get paint out of a paintbrush.
So silly. Yeah, it just won't let me. Now I escaped the whole thing.
Oh my gosh,
right.
There's Joanna.
Hi, Dr. Resnick.
How are you?
I'm doing good. Everything's great.
That's so nice. All right, let's see.
Okay, getting rid of paintbrush and GoTo meeting. Wow, they do not.
I got it.
Question. Okay.
Yeah. All right. I think I can move this slide now. Let's see. Slideshow. Okay. Can you see that?
Yeah, I can see it.
Okay, great. Can you go from that?
Yeah,
you already do this one?
Yeah, it's fine.
Okay, thanks.
So basically, in order to like confirm, so we have to basically confirm if you have a Brca mutation or HRD, or if your tumor has a mutation. So we have to do what's called a companion test with any of these things. Most of us use foundation medicine. Most providers do. It's easy. It's how we send off your tumor. Most patients will be sent for genetic counseling. To my patient who said hello to me, yes, I'm now remembering you actually do need to go to the genetic counselor. We will get you to the genetic counselor at your next visit. So yes, all patients who are diagnosed with the serous ovarian cancer, you need to go to the genetic counselor. We have to check you for a BRCA1, BRCA2 mutation. Your tumors are automatically tested for a BRCA1, BRCA2 mutation when we send it for foundation testing.
Was that to me, Dr. Resnick?
Yes. You need to go to the genetic counselor, but we'll get it done.
Okay.
All right. I love it.
I didn't want to use your name, HIPAA.
Okay, did it go to the next one?
Yep.
Okay, I'm just clicking on the side here. I don't know.
Okay. So what is the benefit of Parp maintenance? So we talked about how like your genetic makeup can affect how you respond to Parp maintenance. And obviously the most improvement we saw, like the best improvement, I think was 16 months, were in those patients with a BRCA mutation. So yes, I mean, if you have a BRCA mutation, you're going to hear your GYN oncologist say like, wow, you're not going to want to hear that you're lucky, but you're kind of lucky because it is actually lucky to have a BRCA mutation with an ovarian cancer. It improves your responsiveness to platinum. It improves your overall responsiveness to chemotherapy. The least improvement, but improvement still seen, was in those without any mutations. So again, like just you have ovarian cancer, there's no special mutation seen, but you had a great response to platinum-based chemotherapy. So this is all sort of predicated on the platinum response. So this is not, sadly, talking about women who upfront did not respond to platinum-based chemotherapy. Okay, so parting thoughts on PARPs. 3 FDA-approved drugs. We can use them as treatment or maintenance. Most patients with serous epithelial ovarian cancer will see a PARP inhibitor at some point in their treatment course. And again, how we use it and which one we used is based on sort of physician preference sometime. Most of the time it's based on any sort of special genetic indications. Sometimes it's based on how your bone marrow tolerated chemotherapy may be. Maybe you are going into this with platelets that just don't want to behave. So obviously Zejula is not going to be a drug for you. Maybe at baseline you have terrible GERD. So Rubraca might not be the right drug for you. So looking at sort of the side effects and any sort of baseline comorbidities that you might have going into this period. Now I'm just trying to read this. So this is the activity of the single. So this is actually looking at PARP. I'm just going to get some glasses. Hold on. Okay. So this is looking at the activity of PARP inhibitors when we're actually talking about them as treatment. So again, switching modes here. So this is women with BRCA mutations using PARP inhibitors. There we go. As treatment. So when we look at the number of prior lines, olaparib, so we're looking at Lynn Parsa, Rubraca, Zejula, number of prior lines, more than 3, more than 2, more than 3. When look at these response rates, right? So this is what we're talking about. These are why these drugs are so important in this arsenal for patients with Brca mutations. Overall response rate, 34% response rate in somebody who has had more than 3 lines of prior therapy. That's insane. We never saw numbers like that. 54% response rate, 39%. That's why these drugs were a breakthrough, because we never saw anything like this before in patients that are heavily pretreated. So 2014, in 2014, we had approval for maintenance therapy post-response to platinum in women with recurrent Brca-related ovarian cancer. And then in 2017, we expanded the approval for maintenance treatment in those who had upfront therapy. So 2017 was basically sort of when the gates opened. So that was the first time that we saw approval for maintenance treatment, which this was the game changer in ovarian cancer. I remember, I think this approval came out when I was standing in a grocery store, and I actually did have a patient that was a Brca mutated that had just finished her frontline treatment. And this was the beginning of this era of maintenance treatment for us. And so this is now sort of where 5 years later, this is where we are. It's now standard of care for women who respond to platinum to get maintenance treatment with a PARP inhibitor. Okay, so now we're just sort of like, most of us know this. We're just going to move on and talk about a few other things, and then we can do some questions. Obviously, the majority of patients with advanced stage ovarian cancer, sadly, are going to recur. How do we detect your recurrences? You all know by that number that we all sort of get anxious with, but we need to know the result, CA-125. We define our recurrences by how we respond to platinum-based therapy. So platinum refractory, sadly, is we have failed to even respond to our initial therapy, or we've grown on platinum, or we have grown within a month of stopping our platinum initially. Platinum resistant is we have recurred within 6 months of our last platinum-based therapy, and platinum sensitive means that our recurrence has recurred more than 6 months out after our last platinum-based therapy. Ideally, we would love to see it way more than 6 months out. We would love to see it 12 months out from our last platinum-based therapy.
Let's see. There we go.
Okay, so the strategies that we use for treating platinum-sensitive ovarian cancer. So up front, you guys all know, after chemotherapy or after surgery, everyone gets platinum doublet chemotherapy, unless you're on a clinical trial, right? So everyone gets typically carboplatin paclitaxel-based chemotherapy. And now we are, obviously we are now in a new era where we are doing Parp inhibitor maintenance. You may also see Avastin maintenance. So Avastin maintenance is not thrown out the window. And so there are going to be decisions that are made typically before the end of your treatment about which maintenance treatment is right for you. And you may end up having a discussion about whether bevacizumab maintenance is right for you. There are patients, there are select high-risk patients that we are still, using bevacizumab, otherwise known as Avastin, in upfront. Some stage 4 patients that present with brain mets, bevacizumab is indicated in these patients up front. We used to give bevacizumab with everything. We have thankfully moved away from that because of the side effects of it, but it is beneficial in some of these patients. So for those patients, Avastin is still a really good drug to use in the maintenance setting. So for some patients, the Parp may not be the right drug for them in the maintenance, and they might be talking about getting an infusion of Avastin every month. And I love Avastin as a maintenance in some patients, and will still use it even after a first platinum recurrence. I will use Avastin for maintenance. It's great, and it works. Immune checkpoint inhibition, right? This is what we're all talking about. Immunotherapy. We've all seen the commercials. Everyone wants to know about Keytruda, right? I wish that it was exciting as with the other cancers, right? Because the story with the other cancers is amazing, right? We're like curing melanoma. We're curing all these other cancers. The story just isn't the same with ovarian cancer. The story is pretty amazing now with cervical cancer, but it's not quite there with ovarian cancer. So our immune system actually tries really hard to get rid of cancer. It does. Our immune system relies on multiple checkpoints to avoid overactivation of healthy cells. So basically what happens is tumor cells realize that the T cells are out there looking for them. So tumor cells basically hijack these checkpoints to escape detection by our own body's immune system. So they sort of steal these jackets so that the body recognizes the tumor as self and not like cancer, so that the T cells pass them by and aren't like, danger, danger, I should get you. So that these cancers are sort of stealing these little signals, CTLA4 and PD1, and we find that we see upregulation on T cells of some of these little signals in some cancers, because the T cells are sort of ignoring the cancers. So PD-L1 is being expressed on the cancer cells in association with the T cells that are ignoring the cancer cells. So what we're trying to do is we're trying to block this interaction so that the T cell learns what to do, so that the T cell basically learns to pay attention to the cancer cell. So these drugs are actually not going after the cancer cell. They're basically just taking over this checkpoint so that the T cell actually learns what to do. So this little cartoon right here, I just put in sort of where we see the two drugs that you're going to hear most about in GYN cancer, Keytruda and Opdivo. And so you'll see the tumor-specific T cell is at the top. So that's a T cell that is sort of made specifically for this tumor. It's expressing PD-1. The tumor cell is presenting PDL1. It's basically telling the T cell to ignore it. It's telling the T cell that it is self. I belong in the body. Ignore me. Okay? So Keytruda and Opdivo, their job is to sort of get rid of the PD-1 from the T cell, to tell the T cell basically like, wake up, do your job, go after that cancer cell like you're supposed to. Okay? So what we're doing is we're revving up the immune system, which is why all of the side effects of these drugs make complete sense, because they are all autoimmune diseases when you look at all of the side effects of this class of drugs. So we do have some data for Keytruda in ovarian cancer. So let's see where this is going. So most patients with ovarian cancer relapse after first-line therapy. So this is platinum. Okay, recent trials. There we go. So Keynote is a trial that used Keytruda, which is otherwise called Pembro. We'll call it Pembro for short, so I don't have to keep saying a mouthful. And so Pembro actually had an overall response rate of 11.5%, 8% overall response rate in patients with advanced recurrent ovarian cancer. So again, this is not great, but these were patients who had been heavily pretreated. So these were patients that had had multiple lines of therapy, and this is showing some activity in patients with recurrent ovarian cancer. Again, not as brilliant as the responses that we're seeing in patients with endometrial cancer and cervical cancer, but still some response. And it's great because these actually are really well-tolerated classes of drugs, despite the autoimmune side effects, which we'll see in a moment. They really are well-tolerated classes of drugs. So we can see right here, the cohorts here were just different, how heavily pretreated these women were. So again, overall response rate, not great, 8%, 9%. This kind of is in line with what I tell patients whenever I have a very heavily pretreated ovarian cancer patient. What I end up quoting them is that there's probably less than a 15% chance of me finding any one drug that is going to have a meaningful response. The best overall response in this patient group, again, was a partial response. You can see a PR. Again, not a huge number of responders. You can see that in cohort A, we had 285 women, 23 women responded. But again, look how long they responded for. So look at that, even though it's a small group of women, look how long they responded for. A median time of 8.3 months. Look at the longest responder though, 35.4 months plus. So it's all about finding one drug, right? One drug that works. And it's not about snake oil or therapies that don't mean anything. It's about finding a therapy that makes sense for a patient. And if we can get an insurance company to approve this in a patient, or we can get compassionate use, there's no reason to not try when we're sort of at a point where we are thinking that we don't have great options. And so you can see here, all of these are the immune-mediated side effects, because again, we're asking the um, immune system to rev up. We're basically telling the T cells, hey, pay attention to this cancer and pay attention to everything else that's going on in the body. So, I mean, it's interesting. I've seen a myriad of just crazy side effects now from these drugs, but you can see we screw with the thyroid. So that's the number one thing we see. So we're checking the TSH every time we give a cycle of chemotherapy. We see colitis. I've seen pneumonitis at this point. Diabetes can develop. We can see adrenal insufficiency. I had my first patient actually develop rheumatoid arthritis from Keytruda. She had fulminant rheumatoid arthritis with like a hot joint, a rheumatoid factor in a patient that had never had rheumatoid arthritis before. We can get immune-mediated hepatitis. I've had a patient with immune-mediated myositis, immune-mediated myasthenia gravis. So pretty much if you can think of it and if it exists as an immune-mediated disease, you can get it from Keytruda. The treatment is high-dose steroids in all of these cases and stopping the drug. We can usually successfully re-challenge the patient if the patient feels safe enough and they want to be re-challenged, if it wasn't a life-threatening sort of issue. In my patient with pneumonitis, we re-challenged them because she was easily treated with steroids. Obviously, the thyroid conditions can all be treated with appropriate medications. Sometimes the myositis, not so much, because the patient had pretty significant issues with her muscles and wasn't too interested in going back on Keytruda after that. But a lot of these we can treat them successfully and get the patient back on the drug, especially if the drug had been working. I'm going to list, literally, this is like the one slide I have on Hypec. It is done, and it's done by people that do a lot of Hypec. So I will say right now that there's really one indication for Hypec. Otherwise, it still is experimental. So the one indication for Hypec right now is for patients with stage 3 ovarian cancer who are not able to undergo upfront tumor reductive surgery, who undergo neoadjuvant chemotherapy, and then who are undergoing their interval debulking. They might benefit from Hypec chemotherapy. And again, that's might. It's not a definitive, but these are the patients who have shown benefit from it. And there actually is an ongoing trial right now in Denmark where they're hypothesizing that they will continue to see the same improvement in patients who are undergoing their primary cytoreductive surgery if we also give them Hypec.
Can you just explain like what that is briefly?
Hypec is where we give you heated intraperitoneal chemotherapy. Where Hypec was invented was in patients with pseudomyxoma peritoni. So it really was, I'm having word finding difficulties today. It was pioneered at UPMC in Pittsburgh by a man named Dr. Sugarbaker for patients with this disease entity called pseudomyxoma peritoni, which is really sort of a GI tumor, otherwise known as jelly belly, where they wind up with sort of mucus all over their abdomen, and you have to strip out all of their peritoneum and get basically every tiny bit of disease out. It does sound a lot like ovarian cancer, and the goals usually are the same. The dissections can be a little bit different, and the way we describe our resections are different. And the reason that Hypec works so well in those situations is because other treatments in that disease entity were abominable. Like there was absolutely nothing that worked for pseudomyxoma peritoni. The difference being that we are exquisitely sensitive to chemotherapy up front in ovarian cancer. So that's the difference, is that we use Hypec in a lot of disease entities where chemotherapy doesn't work, like mucinous GI cancers, where like the outcome is terrible, and like poorly differentiated signet cell tumors of the colon. Like where the outcomes are horrifying. But we have chemotherapy that works really well in ovarian cancer. And so again, certain ovarian cancers, this might be reasonable, like a mucinous ovarian cancer, which does not have the same prognosis, natural history as high-grade serous epithelial ovarian cancer. And again, it really does require going to a center that does a lot of these, talking to a physician that does a lot of these, and really understanding the risk, benefits, alternatives, outcomes, and what all of your options are. So this is just talking about a new class of drugs. So a new class of drug that's sort of like on the horizon that you may or may not have heard of is called ADCs. These are otherwise known as smart bombs. So a current trial that's using a smart bomb is the Mirasol trial. And so we do currently have this trial. So this is an antibody drug conjugate smart bomb. So basically it is like using an antibody to basically like sneak its way into the cancer cell and then like drop its drug off, and the drug is like, phew. So it's kind of cool. Again, a whole new class of drugs means a whole new class of toxicities that like we are not used to, because GYN oncology is usually late to the party, because usually the rest of oncology has been doing this like way well before we are. So the Mirasol trial is actually looking at high folate receptor alpha expression. So patients' tumors actually have to meet criteria before you can enroll in it. 40% of ovarian cancers will demonstrate folate alpha receptor expression. So the tumor actually has to have that receptor in order to get enrolled on the trial. This is for platinum-resistant ovarian cancer, which is exciting because again, treating platinum-resistant disease is challenging. However, we don't believe the 40% number, because so far everybody we've screened has not demonstrated this receptor, but we are not giving up. So the main difference is we're seeing ocular toxicities for the first time. We've never really had to deal with ocular toxicities from essentially any drug we've ever given a patient. Patients will note, their vision changes a little bit on chemotherapy. Sometimes they need a new prescription, but like this is legitimate ocular toxicity where we have to have a ophthalmologist involved. They have to undergo eye screening. We use steroid eye drops. And this is really a whole new class of drugs that we're going to be seeing a lot of in GYN cancer. And the whole class of drugs has this ocular toxicity. So I think this is going to be something that we are not going to get rid of. It's going to be probably something new that we're seeing. Just a picture here. So you can sort of see the antibody drug conjugate. The antibody binds to the receptor, and you can see that it has its little, so the yellow dot is the cytotoxic drug. It has a little linker, which is the yellow sort of linkage, and it sneaks its way in and then drops its bombs off in the cell. I think that's pretty cool.
That's cool.
Yeah. Thank you. I always end really, I like end it.
Thank you.
A surprise ending.
Oh, that's great. So if y'all want to, if you want to put your cameras on, and if
I
you
would
have,
love to see faces. I do.
yeah, just because we'll do we started a little late, so we're gonna go over. But if you just kind of want to wave, I can unmute you if you have a question. Again, for Dr. Resnick, so we're not doing a full consult here. Something. So
oh my God,
Susan. Yeah. So just something general that you think your peers might also, benefit from that question.
Susan and I did have that one time. I think it was last year. I did a full consult. Like everyone was sitting there, and I was like, oh my God, it feels so bad for everyone here.
Yeah, and I'm going to stop recording if I can.